So we are coming to the end of the session. Last talk will be by Dr. Sujith Nayanar. He's the senior most cornea specialist at Trinity High Hospital. Over to you, Dr. Sujith. He'll be talking on laser-based refractive options in presbyopic age group.
Very good morning. Thank you for this opportunity. And the topic of this last topic of this IC is laser-based refractive options in pediatric age group. The title is laser-based refractive options, and it's not about the presbyopic LASIK. So, excuse me. Can you make it present to you? So, as this quote says, many of us, the life starts at 40. After the initial hurdles in life, they start exploring the world after 40. So but that's about the mindset. The body has something else in store, and it starts showing up the signs of aging. Especially it starts with the eyes, and they start thinking that my vision is not as good as it used to be in the younger age. It's basically due to the difficulty they face while adjusting with the multiple focal points as they approach the presbyopic age group. We are sometimes surprised, like why at 40 they come with this request to undergo a refractive surgery. Actually, by the time when you look at it, I think there is one article also on it. They've studied why people come back at 40 for refractive surgery. They are more settled in life. They are financially stable. Sometimes they are actually, in my personal experience, they are mostly inspired by the younger generation, the children who have undergone LASIK, and seeing the wow effect, they want to try it in themselves. Now they think that they have the wisdom to judge and decide by themselves. They don't have to depend upon the parents. So all these things, and health as an investment, not as an expense, they are considering. So, and now they are coming back at 40 requesting for a refractive surgery. But what is in the mind is something different from what we see. It is just a journey that begins at 38 or 40, and they have to go through another 10 to 20 years, which is a dynamic process which is affected by multiple factors. So it's not as easy as in the younger age group. They correct it once and they have the result for a longer period. So this is a main challenge as a consultant or as a doctor practitioner. We have to tell them, or as a challenge for the practitioner is to give the same visual quality or optical quality for far distance and intermediate. So this is adapted from an IGO journal, article in the IGO journal, which in which the age-wise categorization of the refractive surgery was shown. So above 40, they have categorized it into two groups: the one with the DLI OK and other with the DLI less. So DLI is the newer concept of grading the dysfunctional lens index, as a new term, which tries to explain the dysfunction of the clear lens. Morphologically, there is no cataract, but the lens is not acting or giving the clear image as it used to be. So this is the index which they see or look at to decide on an early refractive lens exchange. So anything more than 7, they say they are having good visual index, visual acuity, and anything less than 5 is said to be a very bad DLI. So with that concept, anything more with the less DLI, they are suggesting refractive lens exchange. Better DLI, go for the laser. The laser options. Can you make the other presentation? Okay, I'll do it. Okay. Thank you. So laser-based options that can be offered are basically, what is practically possible is LASIK. We used to do conductive keratoplasty and all previously, but I think it has been phased out due to the poor results or poor long-term results. In LASIK, we have two options: either a monovision LASIK or a presby LASIK. And in a difference to what a normal younger patient LASIK, we need to have a very long chat with the patient. We have to patiently understand what is the patient's requirement. and they have to understand right from the optics of presbyopia to what is going to happen in future for the next 10 to 20 years regarding the normal change that is expected in the vision. So this is what I stressed in the title. When you look at the presbyopic age group, it need not be always a presbyopic LASIK. You can always offer them a normal LASIK also, but they should understand that they have to use glasses for the near vision. That is the simplest thing that you can do. The second thing is, if they are very persistent that they want to be independent or less dependent on glasses, that's when you consider the presbyopic LASIK option. And it again depends upon the basic refractive error they are having, whether they are hyperopic, emmetropic, or a myopic patient. So the presbyopic LASIK, again, presby-LASIK as it is called, has three types are there. One is the central, peripheral, as well as the laser blended vision. Going into too much into the details of this is beyond the scope of this talk, because this just to introduce what are the options in the presbyopic age group. These are the machines that offer the treatment of presbyopic LASIK. Three main types. The first type is the central presbyopic LASIK, that is more popular and more done in most of the places where they are conducting it. The basic principle here is the central cornea is a multifocal ablation, and where the central cornea is used for the near, as well as when the peripheral cornea is used for the distance. The ablation is less, and it takes very less tissue from the center of the cornea. In peripheral LASIK, it's I have time now, sir. Last talk, no? So peripheral, it's just opposite. The center is for the distance and the periphery is for the near, which is not a physiological thing, and it's not a very popular method. The results from the literature shows that there is definitely a loss of the distance vision by 1 or 2 lines in more than 40 to 50% of people. They have good near vision, but the loss in the distance vision has to be accepted and told. Another thing is the increase in number of the retreatment. The retreatment is almost 20 to 25%. Basically, probably these are the reasons which they have told that it's inability of the older patients to accommodate. The nomogram is not refined, the healing responses, nuclear sclerosis, and all those things. The other option is the laser blended refraction, laser blended vision. So, 2-3 slides. Here they are. It's also a popular method. Here what they are trying to do is it's just like an EDOF lenses. They are trying to adjust the spherical aberration and trying to increase the depth of focus, and in this what is happening is actually we have a distance between the distance and near, we have a blur zone. They are trying to blend that near vision to that blur zone by inducing a little bit of spherical aberration. You have to do a plus 1.5 diopter test in the non-dominant eye and see whether the patient is accepting it, and that is one test which you have to do and see whether this patient is an ideal candidate. Another option is going for a standard micro mono vision. Here it's direct one eye distance, one eye near, almost 1.5 diopters you undercorrect. It's very clear, one eye distance, one eye for the near, but in the other one there's a blend zone which is adjusted in the non-dominant eye. Here the adaptation time is little more, but there is always a second chance here. If the patient is not adapting, even after 1 month, you have to tell the patient initially, you can even go for that eye, the non-dominant eye also, you go for full correction, and just they have to accept the near vision with glasses. So it's basically a trade-off, like you have to compensate at some part of your vision, either distance or near, and we have to understand that we are training our brain to learn the new type of vision. Patient selection, you have to check the dominant eye, avoid high demanding patients. The professional requirement has to be well understood. The trial of 1.5 diopters is important, and better avoid low myope presbyopes as well as the emmetric presbyopes. And the general principle about the planning is, in the presbyope hyperopes, it's always presby-LASIK or refractive lens exchange that is advised. Low to moderate myope presbyopes are a difficult group where you have the option of blended monovision or the LASIK with the near vision. High myopes always go for either phakic IOLs or selective lens, refractive lens exchange, understanding all the proper risk factors. Myopes again, as I told, it's just the same thing. Low myop presbyope, why it is difficult is because if you go undergo a LASIK with the distance correction and just near glasses, they are never happy with the near vision that they used to enjoy without glasses. If it is a monovision, they have a compromised depth perception. If it's a multifocal ablation, the lack of clarity is always a complaint. So this is a very small personal experience which I thought I'll discuss, but there's no time. I'll skip this. So in conclusion, we need more chair time with the patient, multiple sittings, proper patient selection, age lab and patient requirement should be well understood, realistic promises should be given, reversibility and repeatability is always should be kept in mind, and alternate options should be discussed, and this is still evolving. Thank you.
Thank you, Dr. Sujith.